FRêMITO, o podcast vascular do perfil O Fogart da Madrugada.
Esse é o FRêMITO Podcast Vascular, direto do Congresso Science 2024, e a gente está tendo a honra de receber o Dr. Giovanni Rossi, que é da Itália. Ele é o head da cadeira de cirurgia vascular, endovascular, e também do time de AORTA em Milão. Dr. Rossi, very welcome to have you here with us.
Thank you for your kind invitation.
For all those that can saw your lecture here in the Congress, do you think that it's possible to treat ascending aorta with endo?
It's a good question. The answer is actually no. Because actually the best choice, the best option is for sure open surgery, sure. Even if it's burden from mortality, relatively high mortality and morbidity. But there is some cases where we can use as a rescue solution endo approach. Mainly when the patient is considered to be a high-risk patient from a cardiac surgeon or an anesthesiologic team. Mm-hmm. So in this case, we have to think out of the box.
Sure.
We have to try to approach and to find some solution in order to bridge the extremely difficult situation for the patient, probably leading to the death, and try to find a solution.
You were talking to us before those three different cases that you had in your service. Could you tell us about it?
Three different cases. I think that three cases different but similar. Three cases of patients ranging from 60-year-old to 18-year-old. Refusal for many reasons. This is not important. Why refusal from a cardiac surgeon, and it's quite usually in our experience that we have to treat the leftover cases of cardiac surgery. But in these three cases, there is two complications of previous cardiac surgery. I mean, two pseudoaneurysms, one proximal and one distal, and one cases of intramural hematoma. The approach is very difficult for some order of a problem. The first problem that actually we don't have a dedicated device of the ascending aorta. Uh-huh. We have to use the abdominal cuff.
Okay.
But the length shaft of the abdominal cuff is short to reach the zone 0. Uh-huh. Mm-hmm. So in this case, we have to use one axillary approach. And the other problem is that the length of the ascending aorta is very variable, and the landing zone, proximal distal, are very dangerous. I mean, distally or proximally, depending from the heart, we have coronary artery.
You must be very precise.
Yes, we cannot close obliquely coronary artery. It's more acceptable to close the innominator artery or the carotid artery, as I done in one case, because we can perform a hybrid solution by extra-anatomic bypass. Perfect. But in this case, when we have the possibility to use a long TEVR device, we can pass into the femoral artery. Otherwise, we have to pass into the axillary. And the second problem, the third problem, is the length of the ascending aorta is different in the outer curvature or in the inner curvature. So we need a very flexible device in order to approach correctly. And all the procedure had to be performed under rapid pacing, but this is not the main problem. In one case, since we have a proximal landing zone of 10 millimeter, we placed one rescue guide in right coronary artery. Because if someone goes wrong, we had the possibility to stenting rapidly the right coronary artery. It's not a good situation, but if we have a rescue, for the rescue,
as a bailout,
yes, bailout is an optimal solution. All the patient goes well. One case was interesting because in the setting of the aortic team, we started to treat the patient in order to reduce or close the proximal pseudoaneurysm. And the second step, the cardiac surgeon done the redo in order to keep out the device and perform aortic valve substitution with freestyle in this setting.
What do you think about customized devices for
customized excellent, but not in emergency. Actually, we need absolutely, for sure, we need of a dedicated device, because the custom-made solution are the good solution, but we have a waiting time in the real world 1 month, at least 1 month. The second problem is that the custom-made device work on a platform not dedicated. So when you're working in the aortic arch, the right landing zone, the sure landing zone is zone 0. Because you can avoid Burbick, you can avoid migration. The zone 0 is the right zone. But you depending on the length of the ascending aorta. So okay for a custom-made device, but dedicated custom-made device. We cannot use the platform of the abdomen of the visceral vessel for ascending aorta.
So, for example, PMEGs, you don't think there is space for that on the arch?
PMEGs are excellent solution for zone 2 and zone 1.
Okay.
And the second problem is that you need a learning curve.
Yes.
You need a learning curve because PMEGs is very interesting, but you change the structure of the device. Mm-hmm. Okay, you are in emergency situation, so never mind. But you change really. You may have a problem of stability on the future, because I don't know exactly what will happen when we change structure of the device. And even in the best trained hand, it's time consuming. Almost 1 hour, half an hour to perform, to change. And sometimes in emergency situation, 1 hour is really too much. Mm-hmm. I think that the best solution for the theoric point of view is in situ fenestration.
Okay.
Situ fenestration, but there is one device in the market used in China, and there is some experience, huge experience, as usually in China with fenestration, but we don't know exactly what is the follow-up of this patient.
There is so many challenges to treat cases like this one. Obviously, the landing zone is a very huge challenge. But in my mind, how to revasc the brachiocephalic trunk is totally different than the left subclavian artery, or...
Yes, but one more time, we have to think out of the box, because usually when we think about the branch, we think about right to left. For us, it's normal to think carotid subclavian bypass, right to left, but it's the same.
Yes, we can
from
do
the left to the right. The opposite is absolutely the same. So if I have to cover the innominated artery and the left subclavian artery, I can start from left subclavian artery and go to the right by the reimplantation of both carotid arteries. It's very important in these cases, think out of the box, because you have to change any mental paradigm.
And what about the extra anatomical bypasses? To use the...
No reinforced graft.
Okay.
Absolutely. Dacron graft.
Okay.
Plain old Dacron.
Retrosternal, but it's so simple. It's not difficult to perform. Only the brave.
Let me ask you something.
Let's go.
When we move a little bit more proximally, so when we have valve to change, we know like the BRAILE, Brazilian industry, they also think out of the box often.
Yes.
And we know that they once did like an endobental. So they changed the valve and the grafts and branches to the coronaries. What do you think about that?
I think it's wonderful, because we have actually just the ascending aorta is just for cardiac surgeon. So vascular surgeon arising from zone 3, zone 2, zone 1, and now we have to arrive in zone 0. And we cannot arrive in zone 0 without manage the valve. So I think that the final target is to have one solution with a complete treatment. So a complete treatment with endobental for the stenosis, but also for insufficiency, but also for the normal valve, because this is the problem of study. So the combination of endobental with distal zone 0 should be the better option, and we are waiting for that.
Nice.
Very nice. Thank you, Dr. Rossi, for your
You're
explanation
welcome.
here. And I really want that you gave us a message for the vascular Brazilian surgeons that can't be here today.
Like a take-home message.
Take-home message, if I repeat two messages. The first, if work inside the aortic team to choose the best solution for the patient and not for the surgeon. This is the first. And sometimes the problem arises from a difficulty to share. When we analyze a CT scan, each surgeon had to propose the best for the patient, not the best for the surgeon. This is the first. And the second, I repeat, think out of the box, because there is some rules in surgery. There is some rules in endovascular, but sometimes we can change the rules.
That's it. Thank you very much, Dr. Rossi. I hope that you enjoy your stay here in Brazil.
I hope too.
Não deixe de continuar curtindo e aproveitando os episódios do FRêMITO Podcast Vascular, direto do Congresso Science 2024.
FRêMITO, o podcast vascular do perfil O Fogart da Madrugada.